Mhm. Peter, if you're there, if you could kindly share either the poster or the agenda on the screen, even as we await to start. I'm just giving participants a few minutes, okay, and then we shall begin. Good evening, ladies and gentlemen, and welcome to our webinar tonight, which is hosted by the Kenya Medical Association in partnership with AVACARE. Today we have very powerful presentations by our very senior doctors. We have Dr. J.A. Aluoch, Dr. Omondi Oyo, and Dr. M.D. Minor, who are the best of the best in our country and have been our teachers. So welcome, colleagues, even as we begin this presentation. As is being shared on screen, that is as has been shared on screen, shall be discussing in the various specialties that shall be discussed tonight. So without wasting time and going straight to our first presenter, I will go ahead and introduce Dr. Joseph A. Aluoch. Dr. Joseph A. Aluoch is our very senior member at Kenya Medical Association, and we are very grateful to be hearing from him today. He's a consultant physician and a chest specialist at the Nairobi Hospital, Kenya. He qualified as a doctor in 1968, very long time, and he has a very big book in which he has written all his experience over his 52 years of practice in Kenya. He has obtained a specialization in the United Kingdom as a physician and now holds an FRCP from Edinburgh, FRCP Glasgow, diploma in tuberculosis and chest disease Wales, and has landed several spots in the Ministry of Health and was director of TB in respiratory research and honorary lecturer in the University of Nairobi Medical School till 1986. After retiring, he continues to practice as a consultant chest physician and serves in various boards and organizations within Kenya, and being chairman of various medical associations in Kenya, Kenya Medical Association being very proud to be associated with you, Dr. J. Aluoch. He is currently the patron of Kenya Association of Physicians and Respiratory Association of Kenya, President Pan-African Thoracic Society. He's 2017 recipient of honorary member in the National Union Against Tuberculosis in Lung Diseases. He has authored over 60 papers in local and international peer-reviewed journals and has authored his autobiography, In the Footsteps of My Father, and a historical perspective of 50 years of medical practice in Kenya. So Dr. J.A. Aluoch will be presenting on the systemic steroid in asthma, striking the balance between efficacy and safety. Dr. J. Aluoch, karibu sana. Feel free to put up your presentation.
Thank you, Liz. That's a little longer than what I was going to present. That presentation, introduction, I'm not sure whether it was meant for me or somebody else that I'm not familiar with, but it's possible it could have been me. Okay, but I'll take it. And let me thank KMA for organizing this and also AVACARE. So I'm glad to share the panel with prominent students of mine like Professor Yu and Dr. M.D. Maena. Now they look a little older than me, but that's fine. So I'll start by talking about systemic steroid treatment in asthma, striking a balance between efficacy and side effects. Well, let's talk about asthma. Asthma is a chronic disorder of the airway, which is characterized clinically by recurrent episodes of wheezing, breathlessness, cough, and chest tightness, particularly at night or early morning, and it's reversible narrowing of the airways and marked increase in bronchial hyperresponsiveness or hyperreactivity. It is a heterogeneous disorder, and currently there's no universally acceptable classification. But broadly, we can classify into two groups, atopic or extrinsic, or which is allergic, which constitutes 70% of the asthmatics, and IgA-mediated immune response to the environment antigen. Then a smaller percentage, about 30, belong to the non-atopic or intrinsic group, which is triggered by non-immune stimuli. Patients in this group have negative tests to common inhalant antigens, and they have normal concentration of IgE. But in any case, the ultimate response, humoral and cellular mediator airway, is the same irrespective whether it is atopic or non-atopic. The inflammation and result the same, and hence treatment is also the same, does not differ much. And the bottom line of asthma is inflammatory state, which often have an acute inflammatory episodes, which involve say, respiratory mucosa from the trachea to the terminal bronchioles, predominantly in the bronchi. Often it's called eosinophilic bronchitis because of the propenderance of eosinophilic inflammatory cells and with a lot of mast cell infiltration in the epithelium. It has T helper type 2 response, which involves interleukin 4, 5, and 13. We know that interleukin 4 stimulates IgE production. Interleukin 5 activates eosinophils, and interleukin 13 stimulates mucus production. These are all inflammatory mediators. So in the background of understanding pathogenesis of asthma, then we can look at how glucocorticoids or systemic steroids will be useful in controlling this inflammatory process. Let us look at the mechanism of action of glucocorticoids. First and foremost, the inhibition of phospholipase A2, which reduces the prostaglandin and leukotrienes in the airways, and reduce the number of inflammatory cells in the airways, reduces the mast cell, stabilizes the mast cell so that there's a reduction in histamine release, which may be responsible for capillary permeability and mucosal edema, and inhibition of antibody reaction is also carried out by the steroids. One final property is that it upregulates the beta-2 receptor so that beta-2 agonists have got a more effective treatment response in asthma. So the anti-inflammatory action of steroids will reduce the number of cells in the airways, induce eosinophil apoptosis, prevent the reverse increased vascular permeability, and above all, decrease sputum secretion. Eventually, you have airway responsibility reduced and a healing process. only suppresses inflammation. Let us agree on that. It do not cure underlying disease. Hence, recurrence is seen after a recurrence of this inflammation is seen after steroid withdrawal. Classification of asthmas have over the years been divided into two groups, mainly the relievers of the rescue medication and the controllers, or which include the preventive or controlling the attacks, and which is led mostly by glucocorticoids, although there are others. But today we are going to only talk about the glucocorticoids. Now, steroids have been used for a long time. In fact, in 1945, when they first isolated steroids from the adrenal gland by Addison, it was used first in rheumatoid disease. So I'm glad Dr. Yu is here to tell us about it. But it was used in rheumatoid disease before being used in asthma. Treatment of asthma with steroids only started in the 50s, and it took up to the late 60s for it to be used in inhalation form, as we shall see shortly. Now, it reduces airway inflammation in your cells and reduces all the process of inflammation that are associated with asthmatic attack or asthmatic inflammation. But they are not bronchodilators. Hence, often they're not classified as relievers or rescue medicine because they do not open up the acute bronchospasm that occur in asthma. But the benefit by reducing the bronchial hyperreactivity, mucosal edema, and suppressing inflammatory process. Hence, this way, they open up the airways by this process. But used in severe asthma, they are used in a chronic way, and particularly in patients whose asthma is not controlled by the usual bronchodilator in combination with inhaled corticosteroid, ICS. Now, corticosteroids, as I said before, are very effective in treatment of asthma, both acute asthma attack and chronic asthma. Development of inhaled corticosteroids was a major advance in asthma therapy in the late 60s and has been used over the years as prophylaxis or controller therapy in asthma. And it's been shown the use of inhaled corticosteroids or even oral corticosteroids have been shown to reduce the need for rescue beta-2 agonists, and benefits normally start within 1 week and may continue up to several months. And particularly, if asthma is not controlled by low-dose inhaled corticosteroids, addition of long-acting beta-2 agonists sometimes is more effective than doubling the dose of steroids. Corticosteroids usually give a more complete and sustained symptom relief than bronchodilators alone. This has also been shown in several trials. It improves airflow, reduces the frequency attacks of asthma, and influences airway remodeling, which means it reduces or retards disease progression and eventually reduces the development of the so-called fixed airway obstruction in asthma, which sometimes is seen in asthma COPD syndrome. That is where the asthma and the COPD meet. It increases airway smooth muscle responsiveness to the beta-2 agonists. The improvement may not be immediate. It may take a couple of days to 1 week after starting steroid to see the beneficial effect of steroid. Now, in the treatment of asthma with oral corticosteroids, and we are talking about oral or systemic. Oral and systemic are more or less the same. You need in acute attack, you may use short course of oral steroids. And a lot of people have taken to this course of treatment, and most of them in the belief that a short course of oral steroids may not have very much side effect. But this is not true. These have been shown to be false. If you give it 2 or 3, if you give steroid for less than 3 weeks, the side effects are very minimal, okay? And if patients are on inhalers, we can stop oral treatment abruptly. And over the years, pharmacologists have taught that when you start steroid to reduce the severity of the side effect, you should taper it. And this has been on for a long time, and a lot of physicians still use it. But now we know that it is not necessary in most cases to taper the courses of several treatment over a period of time for the maintenance. And if the response to other drugs are inadequate in the long time, administration of oral steroids do help a lot. And if you have the oral steroids on asthma for a long time, it's better eventually to monitor them and transfer them to inhaled corticosteroids, which are probably better used for a longer time. In most cases, particularly the chronic treatment with the oral steroids, it is better to give a single dose in the morning. Hence, one of the drugs we're talking about today, that is corticosteroids, is given a single dose. And this has been shown to have less suppression of the adrenal gland if you give only one dose in the morning. Reasonable dosage does not cause adrenal suppression as cases where we give BD or PDS doses. So patients not controlled on ICS, you can use oral steroids. The dose has not been shown, the appropriate dose has not been shown beyond reasonable doubt, but if you use that 40 milligrams of prednisone a day is good enough, and you can maintain for over the next 3 weeks, 10 to 15 milligrams. And again, as I say, given as a single dose in the morning produces less adrenal suppression, causes much as the diurnal variation of steroids. Alternate day treatment, which was used by others, again, under the impression that it may make the side effect less, has been shown not to be optimal. It is suboptimal, hence not preferred, and is not good pharmacology. Okay, these are some of the common types of systemic steroid that have been used frequently. We often give hydrocortisone injection, prednisone, prednisolone, and methyl, and dexamethasone, which is now used even in COVID. These are strong. Some of these depend on the relative sodium retention, whether they got the mineral corticoid effect or not, which determines some of their side effects and their effectiveness. The most frequently used, and everybody, whenever you have got asthma, all clinicians, they would go in for steroid, particularly oral, particular patients who are not well controlled. And hence, the World Health Organization has also recommended the use of steroid in severe asthma. But first of all, they have to define what is severe asthma. So they've developed a uniform definition, which is severe asthma is uncontrolled asthma that can result in a risk of frequent severe exacerbation or even death, and have adverse reaction to medication, or chronic morbidity, including impaired lung function or reduced lung growth in children. This global definition includes 3 subgroups of severe asthma: untreated severe asthma, difficult to treat asthma, and treatment-resistant asthma. So let us get clear that when we talk of these 3 groups, severe, untreated severe asthma, difficult to treat asthma, or resistant severe asthma to treatment, we are all talking about severe asthma. So all these other names are not necessary, okay? There are a few points we need to meditate on when we're talking about systemic corticosteroids. 1, does systemic corticosteroid therapy compared to non-steroid improve outcome? This is true. This has been shown in several trials that systemic corticosteroid therapy compared to non or placebo does improve outcome, in particular in severe asthma therapy. What dose of systemic corticosteroid therapy is needed? We don't know, but it's been recommended that more than 80 milligrams of prednisone a day is going beyond dangerous zone if you do. So most of them will be less than 80, but preferably 40 on the average. Is IV corticotherapy superior to oral? No. In fact, most doctors, and particularly when they come see a patient with severe asthma coming to casualty, their hand go on for IV injection. And this case, it's important to know that the doctor are treating themselves, they're not treating the patient. Because that IV steroid injection will take place after 6 hours. Even if you give some doctors give it every 4 hours, every 2 hours. It really is bad their pharmacology because it's not having any effect. You're just overloading the patient with the intravenous steroid. So you can start with oral steroid, and the onset of action will be the same as when they give steroid. What duration of corticosteroid is needed? Again, there will be no fixed. There's no studies show exactly how long you can give steroid therapy, but most studies say that after 3 weeks, if your patient is not doing well on oral steroid therapy, you must look for other reason why it's not improving, or at least find alternative treatment. Because when you go beyond that, then you are treading into a dangerous ground of side effect. Then the third one is oral corticosteroid tapering superior to fixed dose corticosteroid regimen after discharge home from emergency department? The answer is no. No need to taper, and you can just use whatever dose you start, fixed dose you discharge the patient on. Next, is a single dose of depot interventional corticosteroid superior to multi-dose oral corticosteroids? Again, no, it's not superior and not recommended. I know dermatologists and rheumatologists love it. They even give it in the joints, but we'll talk about it when we come to that. But in asthma, we do not recommend it. In fact, it should be banned. Finally, is combination therapy with inhaled and systemic steroid superior to systemic corticosteroids alone? No, that's no, not at all. Okay. So, what is the duration of steroid therapy after the patient has been discharged from emergency department where he has gone in with acute attack? Well, the use of short course therapy after discharge emergency has been previously recommended, and for patients with severe attack, up to duration of systemic steroid is essential to complete relax. Resolve the symptoms and return the lung function to the baseline. But it varies with patient and attack, and it's important for the clinician to make his own judgment. Guidelines strongly encourage that treatment with systemic steroid after discharge for asthma patients reduce the relapse to about nearly 12, about average 15% within the 3 weeks. So those patients who've been to the emergency department and discharged without steroid have got a higher chance of coming back to the casualty. Hence, you see a lot of patients almost revisiting emergency department with asthma attack frequently because they are not being discharged on steroid. In a Cochrane systematic review that compared post-ED steroid to placebo, it might that the fewer patients in the steroid group relapsed in the first week and also had less need for so-called rescue operation. But evidence is not strong enough to know whether shorter or lower dose are generally less effective than higher dose, or indeed the latter is associated with more adverse effects. Okay, although some people just put emphasis on the palatability of the medicine and whether the patients are able to adhere it. That's why we come to oral, single oral morning dosing steroid, because it's better adherence, give patient less damage. Those are all side effects which are known to most of us who have used steroid over the years in many circumstances. But there are a few things that we have to take care of when you talk about steroid. First and foremost, it's very easy to access steroid, And it's cheap. It's probably the cheapest and the most effective drug in the world has ever known. And why on earth is so effective and so cheap is because it's natural, okay? So a lot of patients go over the counter, thanks to the pharmacist, and buy this thing. And I've seen a patient of mine who had been taking steroid every time he had an attack in the pharmacies, and the good old pharmacies, for lack of better word, love of money, gave him a high doses of steroid, 20 million TDS, and he did this for 6 months every day, anytime he had an attack. And I'd like you to imagine what she looked like when eventually came to see me, but not very interesting to look at. We need to teach our patients to adhere to inhaled therapies and recognize what to do with oral steroids if they suspect it may give them side effects. And we also know that there's no standardized approach to weaning patients off steroids once they've been on it for a long time with the adverse effects. This is a difficult thing. You probably never know what to do. But there's a problem that a lot of patients with very severe attack in the villages may not have access to a proper emergency department. A lot of them don't have a monitoring system. And there's nobody who is monitoring the prescription, and the pharmacies are not restricted on whether they can give over-the-counter steroid or not. So we need to improve our system to avoid serious adverse effects from steroid overdose over the years. So we must learn rational use of oral steroid by patient education and adhering, and having that access is only by clinicians who are treating asthma, and must also support clinicians to adopt treatment strategies in asthma that will spare oral steroids, and have a policy where you can petition the payers or treatment or the government to make oral, inhaled corticosteroids available at a cheaper price. It is true that inhaled corticosteroids are very useful, but unfortunately, even the cheapest is not as cheap as oral steroids. So you may not blame the patients who go and have a dose of 1 or 2 tablets for 10 shillings. You can get a lot of tablets to help himself or herself improve those diarrhea systems. So in conclusion, oral corticosteroids continue to play an important part in the management of severe asthma. For their well-known and significant effect, they remain a crucial element in the management of this disease. Even after the availability of the so-called novel biological therapy targeting IgE, interleukin-5, and a large proportion of patients will still continue to require oral corticosteroids treatment. Biologics are now available in asthma, but their use is not as widespread as in rheumatoid disease, as Dr. Will be telling us. So it's been easy to replace oral corticosteroids in rheumatoid disease, I guess, Dr. will confirm that, with biologics, but not so much in asthma. It's especially that up to 30% of patients with severe asthma will require long-term oral corticosteroids, and they remain the only effective way to improve asthma and reduce asthma severity and reduce the frequency of exacerbation. This situation is unlikely to change even in the near future, despite the current state of affairs, where we've got a lot of biologics and other anti-IgE molecules being put in the market. But we know their role will diminish in future with the advent of this new biological agent and more therapy. However, although their use is often maligned and often regretted, and a lot of people kind of shy away from it, they cannot be released for now. And further work we needed to explore and optimize the balance between their efficacy and their safety. Thank you, if you have been listening to me.
Thank you indeed, Dr. J. Loach. We have indeed been keenly listening to your presentation, and thank you very much. It was quite refreshing, and I think we have learned a lot, and it has even emphasized some of the webinars we've been having regarding the role of ICS in asthma and even the role of oral corticosteroid in asthma. Just to remind you, ladies and gentlemen, is that this webinar is hosted by the Kenya Medical Association in partnership with AVACARE. And down there on your Zoom platform, you'll see a part for question and answer. Feel free to post any questions to any of our panel of powerful speakers down there. If you're using your phone, you'll get the Q&A on the top right-hand side of your gadget. We'll move towards to our next presenter. Our next presenter was once my teacher in one of the wards in KNH, and this is Dr. M.D. Minor. We always don't know what MD means, but we are happy. That's a very powerful name, MD Minor. MD Minor is a consultant physician and clinical hematologist. He received his training in hematology at the Royal Postgraduate Medical School in Hammersmith Hospital in London. He practices both benign and hemato-oncology. He has worked for a very long time at the Kenyatta National Hospital and has mentored many students at the University of Nairobi, both postgraduate and undergraduate, but currently is in full-time practice in the many major hospitals in Nairobi. Without further ado, I welcome you, Dr. M.D. Minor, to discuss the role of oral corticosteroids in hematology and oncology. Karibu sana, my teacher.
Hello, you can see the slides?
Yes, you can see the slides. We can see you. Possibly you can put them on full screen.
Yeah, full screen. Yeah, that's it.
Thank you. Thank you very well.
Thank you very much for your kind introduction and for the invitation to take part in this webinar. I'm going to give an overview of steroid use in hematology and hemato-oncology. This is a wide subject, and therefore it's just going to be an overview, nothing meant to be very, very in-depth. Now, steroids, as we know them, they are drugs which have varying degrees of exogenous glucocorticoids and mineralocorticoid effect. And in general practice, they will be used in both supportive care, e.g. prevention of allergic reactions and nausea, and disease treatment, most particularly in lymphoid conditions and hormone-dependent cancers. Among the common drugs we use, steroids we use include cortisone, dexamethasone, hydrocortisone, the methylprednisolone, and prednisone itself. Now, the commonest used drug in clinical practice is prednisone, but then prednisone in itself is not active and has to be converted to prednisolone in the liver. Now, once it is prednisone has to pass through the cell membrane where it is bound to respective glucocorticoid receptors located in the cytoplasms. And the glucocorticoids and complex will cause a dissociation with the chaperone protein from the glucocorticoid receptor, enabling this to translocate inside the nucleus. This process is a short process which takes about 20 minutes. Now, the glucocorticoid receptor complex binds to specific DNA binding sites known as glucocorticoid response elements, resulting in gene expression as inhibition. Complex binding to positive GRES lead to synthesis of anti-inflammatory protein. Those ones which are negative back transcription of inflammation gene. Now, this cartoon is not supposed to be comprehensive, but the purpose is to illustrate the desired effect of corticosteroids when they are used in different dosings. On the left side, the corticosteroids lead to leukocyte accumulation, reduced leukocyte function, monocytopenia, reduced complex, and the net effect is an anti-inflammatory effect. On the right side is the immunosuppressive effect, where you have reduced complement levels, lymphopenia, monocytopenia, and reduction in lymphocyte and monocyte function. Now, for the treatment of tumors, the effectivity of these drugs is based on arresting the G1 cell cycle, anti-apoptotic effects, an inhibition of epithelial to mesenchymal transition, and antigiogenic effect. Now, most of the steroids have different potencies, and this is good information because when you're treating patients with steroids, you'll be required to make a choice because they are multiple, so that if you know the potencies of each steroid, then it is easy for you to make clinical decisions and which ones you're going to use. Now, for example, the commonest one used is prednisone. 5 milligrams of prednisone has the same effect as 20 milligrams of hydrocortisone. And 5 milligrams of prednisone has the same effect with 4 milligrams of methylprednisone. 5 milligrams of prednisone has the same effect of with 0.75 milligrams of dexamethasone. That means dexamethasone has 6-fold as potent as prednisone and prednisolone. And fludrocortisone in sodium retention, its effect is 150 times much more than prednisone. So with that information, then it is easy for the clinician to be able to make a good choice or to understand what dosings of the drug they require. Now, the indications of steroids in hematology are very many, but I've listed the common ones we are likely to see in clinical practice. These ones will include autoimmune hemolytic anemia, ITP, immune thrombocytopenia, TTP, what is called thrombotic thrombocytopenic purpura, very rare diagnosis, but very important. Cryoglobulinias. Also, they are important in treatment of lymphoid malignancies, which include chronic lymphocytic leukemia, CLL, acute lymphoblastic leukemias, ALL, lymphomas, both non-Hodgkin's lymphoma and protocols of the past. It has also been used in Hodgkin's lymphoma. It is also used in graft versus host disease, which happens after transplants. And it is also used to treat inhibitors to factor VIII. Those patients who have hemophilia, after they have been exposed on factor VIII for a long time, then some of them develop inhibitors and no longer respond to factor VIII therapy, and the treatment includes using steroids. Now, the doses of corticosteroids are very variable, but it has been suggested that when you're using a dose which is less than 10 milligrams per day, this is a low dose. Doses between 10 and 20 milligrams daily, that will be considered intermediate dose. And those doses which are more than 20 milligrams per day are high dose. Now, the idea is to give the lowest doses and the shortest course of treatment which can control the disease. Reasoning being that these medicines have their own side effects, and then you'll have to weigh the benefit, the clinical benefit from treatment against the side effect caused by the drugs. In clinical practice, I believe in the whole of this country, one of the most common problems involving low platelets is immune thrombocytopenia, popularly known as ITP. Now, as we know, ITP is an autoimmune disease where autoantibodies target the antigen, the 2B3A antigen in platelet surface. And as they circulate through the body, they are destroyed in the spleen and the reticular endothelial system. So sometimes the situation can be very dire and very scaring, because sometimes patients will come with frank bleeding, and the cutograms will be telling you that the platelets are 0 or 5, which is very scaring. Now, among the patients who require treatment who have ITP, the starting doses will be 1 milligram per kilogram of body weight. Now, this is high doses, because if you are like 80 kilograms, it means you'll be taking like 80 milligrams of prednisone per day. Now, sometimes when we have, the situation is very bad and patients are bleeding, our biggest problem is fear of a fatal bleed. So sometimes we are going to use IV methylprednisone in high dose. And the doses range from 500 milligrams to a gram per day, which will be given 3 to 4 days. After 3 to 4 days, then the patient is converted to oral prednisone once a day. Now, I would caution that because ITP is a diagnosis of exclusion, there's always a lot of misuse of prednisone in low platelets in patients with thrombocytopenia who may not have ITP. So it is important to be careful so that when you're giving your treatment, you are sure that your diagnosis is secure and that the patient is getting clinical benefit without having all those side effects. Now, in lymphoid malignancies, steroids are very commonly used, but this is not the case with the solid malignancies. And because we are now keeping ourselves to hematological malignancies, we shall mention the use in non-Hodgkin's lymphomas. Now, in lymphomas, the doses we give are 1 milligram per kilogram of body weight, and they are given from day 1 to day 5. Of course, they are given on the background of alkylating agent, backbones of some other treatment, other chemotherapies. Now, when we stop, after the 5 days, we don't have to taper off the medicines, we just stop. There's no evidence that these patients have suffered any significant pituitary adrenal suppression. So we give for 5 days, then we stop. Now, steroids will also be used in with other malignancies like chronic lymphocytic leukemia, where we use chlorambucil. Now, these are probably old protocols, but there are still patients who take chlorambucil and high-dose prednisone. This is given like 10 to 14 days. So if you're taking 1 milligram per kilogram of body weight 10 to 14 days, that's a lot of steroids and needs to observe cautiously. Then there is the acute lymphoblastic leukemia, where the steroids have made a huge difference. Now, in all protocols, induction protocols of treating acute leukemias, one of the commonest protocols used around is called UCAL12, and another one is called hyper-CVAD. In both protocols, you're going to use steroids. In the ordinary UCAL protocol, we give prednisone 1 milligram per kilogram of body weight, day 1 to day 28. And then we taper it off slowly, because this is a long-time treatment. 28 days is a long time, considering the dosages we're giving. Hyper-CVAD, the D there is because the dexamethasone is used as part of the protocol. Now, the other use of steroids is premedications, for example, when we are using immunotherapy. Now, when we are treating diseases like diffuse large B-cell lymphomas, or when we are using low-grade lymphomas which express CD20, then we use rituximab. Rituximab is an works against the CD20, and it's very, very effective as an additive treatment. So because rituximab is a monoclonal antibody, patients are exposed to reactions, especially anaphylactic reactions. So we normally give steroids, which include IV hydrocortisone. Sometimes dexamethasone can be given. So those are the most important things, the most important indication of steroids in hematological malignancies. Now, they are also very useful in multiple myeloma. Multiple myeloma, for a long time, we had been using melphalan and prednisone. Even today, there are some patients who still get melphalan and prednisone, depending on the doctor's assessment. But we have moved on. Now we are using most of the medicines we are using are immunomodulation drugs, proteasome inhibitors, and like bortezomib. On your left, where you can see the induction frontline therapies, all those protocols have dexamethasone. Now, of note is that the doses of dexamethasone we use for multiple myeloma are high. It's 40 milligrams per oral weekly, and it goes on every week, so long as the patient is on that protocol, which therefore means then people should be careful. They should be watching for the side effects associated with the high dose dexamethasone. In the middle is the maintenance. Once patients get into what would be called the hematological remission, you need to have some maintenance to reduce relapses. And sometimes, other than the drugs indicated there, dexamethasone is also used. So generally, steroids are very, very useful in multiple myeloma, and we cannot run away from them. And their patients have gotten a lot of benefit from those treatments. Now, the other important use of steroids is controlling nausea and vomiting. Now, if you give your patients chemotherapy, if you're not able to control the nausea and the vomiting, your patients will run away from treatment. In fact, that is one of the reasons patients hate chemotherapy so much. Now, you all know about the mechanism of chemotherapy-induced nausea and vomiting, about the vomiting center, and about the efferent from the abdomen, the vagal efferents, and those ones from the chemoreceptor trigger zone in area postrema of the brain. So the steroids will be used in combination with the 5-HT receptor agonist, and they're very effective. One of the steroids most commonly used in this issue is dexamethasone. Now, this table is just a flash to show what other indications in medical practice where you can be able to use especially dexamethasone. Of note, you can see patients who have got spinal cord compression, patients with nerve compression, superior vena cava syndrome, increased intracranial pressure. Now, these are commonly used, steroids are commonly used here, and the steroid used is dexamethasone. On your right is just a guideline of the dosages which you can use depending on the indication. Now, because we are using very high dose steroids, then we must be aware and be able to identify the side effects of these drugs and manage them effectively. Some of them are rapidly evident side effects, which include hyperglycemia, mental disturbances, and insomnia. Others will be GIT disturbances, proximal myopathy, long-term use, osteoporosis, vascular necrosis, cautionary features, and part of the worst ones like adrenal suppression. There is also increased susceptibility to infections, i.e. mononiliasis, and ophthalmic effect, including glaucoma, papilloedema, cataract, and cornea thinning. Now, what this means that when your patients are taking corticosteroids for a long time, then things like ophthalmic review will be very important, and monitoring blood sugars is important, and also assessing and whether they develop osteoporosis. Now, treatment for less than 1 month is considered short-term treatment. Now, you can be able to reduce the pituitary adrenal suppression by giving steroids once a day in the morning. A lot of people are giving steroids in divided doses, but I think there is a huge benefit when you are using once a day dosing of steroids, because you reduce adrenal suppression. Those patients who are taking steroids more than 7 milligrams of prednisone per day, more than 3 months, they are candidates for assessment for osteoporosis. And if osteoporosis is found, then you can manage with bisphosphonate, calcitriol, or hormonal replacement therapy. So in conclusion, the synthetic derivatives of the corticosteroid molecules are widely in inflammatory conditions, autoimmune disorders, hematological cancers. But despite their efficacy, the utility is limited by the harmful side effects of chronic and high-dose treatment. Now, I should mention, because these drugs are commonly available, and Dr. Aluch mentioned they are cheap, the doctors tend to give a lot of steroids, which people should be careful that we should only give these drugs for those people who need them. We should never give them for people who may not need this treatment. So with that, ladies and gentlemen, I thank you very much for listening. Thank you.
Thank you very much, Dr. M.D. Minor, for your presentation. We continue to thank our participants who have kept us company, and currently so far we have 377 of you. Asanteni sana for logging in and sharing knowledge with the various special panel of speakers that we have. So our next presenter is Professor Omondi Oyo. I will be reading his biography in a few. If you just give me 1 minute to get it. Okay, so we are proceeding on very well. We have moved from asthma straight to hemato-oncology, and right now, allow me to introduce Professor Omondi Oyo, who is an associate professor in the Department of Clinical Medicine and Therapeutics, School of Medicine, University of Nairobi. He's the head of the rheumatology unit at the Kenyatta National Hospital in Nairobi, Kenya. Professor Oyo received his medical degree from the University of Nairobi and completed his residency in internal medicine at the University of Nairobi. He obtained his fellowships and gained experience in rheumatology variously from Tel Aviv University in Israel, University of Cape Town in the Republic of South Africa, Tulane University in the USA, Louisiana State University in the USA. He's particularly proud of having attended the Alliance High School. People from Alliance cannot give us a break. In Kenya, that instilled in him the value of serving others and the confidence to know that he could attain a professional career. Professor Oyo has studied international health as a Humphrey Fellowship Scholar at Tulane University in New Orleans and epidemiology at Aberdeen University, United Kingdom. Professor Oyo is a practicing rheumatologist in Nairobi and has over 100 publications in peer-reviewed journals, and is the author of the well-regarded books, Understanding Arthritis and Understanding Back Pain. As an avid lecturer, his CV lists over 100 presentations to audiences of all types in a wide variety of topics. He has served as a secretary and later the president of the Kenya Association of Physicians. He's a past president of African League of Association for Rheumatology, AFLA, past chairman and member of the executive committee of the International League of Association for Rheumatology, ILA, chairman, Kenya Society of Rheumatology, chairman, Association for Arthritis and Rheumatic Diseases of Kenya, founder and chairman, Uwezo Rheumatology Foundation, and WHO Bone and Joint Decade National Action Network Coordinator for Kenya. In the year 2010, Professor Oyo was appointed the Bone and Joint Decade Ambassador for the International Steering Committee, the Bone and Joint Decade, in appreciation of his role in promoting the goal of the Bone and Joint Decade, and in recognition of distinguished professional excellence and service to colleagues and people affected by musculoskeletal disorders. And in the same year, he was also proclaimed as a great mind of the 21st century by the governing board of the American Biographical Society due to his significant accomplishment within and mastery of rheumatology. Professor Oyo is a fellow of the American College of Rheumatology, a fellow of the East and Central Africa College of Physicians, a member of the British Society for Rheumatology, and a fellow of the Royal College Physician of Edinburgh. Wow, Professor Omondi Oyo, I'm actually so honored to be one of your students. Today, I will actually be very happy when I sleep, having had three of my teachers, actually two of my teachers and one of my teacher in extension, Dr. J. Alot. Thank you so much, Professor Omondi Oyo. Please proceed with your presentation. You're still on mute, Prof.
Thank you. Are you getting me?
Yes, we can see you. You please proceed.
Thank you very much, Dr. Gitao, for the warm and kind introduction. I'm honored also to be invited by Kenya Medical Association to participate in this important meeting on corticosteroids. I'm even much more honored to share a platform with my former teachers. Dr. Joel Lodge is my teacher and mentor. And Dr. M.D. Maina was my boss and my teacher also at in Kenyatta National Hospital. They have already covered a wide range of topics in the field of corticosteroids, and mine will be more qualitative, just emphasizing key concepts without going into many of the hard things that they have talked about. Secondly, since the talk is the evening, I'll assume that most of the people are tired and will not be interested in many things. They just want to get what the few things that I'm going to talk about. So I'm talking about the use of corticosteroids in rheumatology. Next. It's not going down. Yes, so I will talk about, these are the outline of my presentation. Corticosteroid was first used in rheumatoid arthritis on 21st September 1948. This was considered as a breakthrough in the pharmacological treatment of rheumatologic diseases. But it has had an eventful and turbulent past. It was initially enthusiastically acclaimed as a miracle drug. Then it had an unacceptable adverse events. And then the use was tethered with a high caution, and then there was vanished scientific interest. But it is still standing strong as an anti-inflammatory and immunosuppressive drug due to its effectiveness. It is important in the therapy of various vasculitides in rheumatology, inflammatory myopathies, and several non-rheumatic diseases, and it is the cornerstone in the treatment of myopathies and vasculitides. In rheumatoid arthritis, initially treatment of last resort on top of the therapeutic pyramid, but it has of late had resurgence as a low-dose co-medication disease-modifying drug. The adverse events of corticosteroids have been better understood, and many of them are now preventable or treatable, like the use of bisphosphonates in the treatment for osteoporosis was mainly promoted by the osteoporosis that we see in patients who use corticosteroids. But generally, the paucity of research on corticosteroids, in spite of this widespread use and longevity in medical practice, there's no sufficient evidence to back treatment recommendations that we have. And there's indefinite role in the treatment of rheumatoid arthritis and other rheumatic diseases. So 70 years after its introduction, use remains an issue of ongoing controversy. There's a lot of controversy on the use of corticosteroids and fierce debates on its widespread use. But it has evolved in the assessment, there's been evolution in the assessment of traditional glucocorticoids, and there's also the evolution in new formulations of corticosteroids. The new formulation that we have in the market include modified release prednisone, liposomal glucocorticoids, selective glucocorticoid receptor agonists. It has also had several decades of hibernation, but now it is having a second youth. It's an old friend with 70 years, but now again having its youth at a time when it's supposed to be retiring. So we are unlikely to witness the retirement of corticosteroids anytime soon because it is just a teenager again. It was first used in rheumatoid arthritis in 1948, and it was the beginning of a new era in treatment of rheumatoid arthritis and in medicine. The first step began 20th century in several animal and human studies on the role of stress on human body and its possible role in the etiology of chronic diseases. So several studies led to its first use in rheumatoid arthritis on 21st September 1948. This was a 29-year-old RA crippled, wheelchair-bound female who walked out of a hospital, and this was considered a miracle. And this led in 1950 of Hench and Kendall together with Resten from Switzerland, jointly receiving the Nobel Prize for Physiology or Medicine. And this is the only Nobel Prize ever granted in the field of rheumatology up to date. So for us in rheumatology, this was a big thing. It has a central element in pharmacological treatment of rheumatoid arthritis. There's also widespread use in high doses and for long periods. And this has led to unacceptable adverse effects, great precaution regarding their prescription, and it has also been used as a treatment of last resort for very severe cases of rheumatoid arthritis. And because of the side effects, scientific interest vanished. But it has remained central in the treatment of vasculitis, inflammatory myopathy, and other non-rheumatic diseases like bronchial asthma, which has been adequately and exhaustively covered by my mentor, Joel Watch. The advent of new treatment options for rheumatoid arthritis, for example, biologics, we thought that rheumatoid corticosteroids were going to vanish, but biologics are often very expensive. They have been found to be insufficient in disease control in some patients, and they also have serious safety concerns like infections. But glucocorticoids are widely and cheaply available. It's among the cheapest drugs, as has been mentioned by Dr. Lowach and Dr. Maina. It has got the best anti-inflammatory effects, and if you're looking for response in rheumatoid arthritis, it's like still a miracle drug, provides symptom relief and disease-modifying potential as a low-dose co-medication for rheumatoid arthritis. And in fact, there's been a lot of debate on the use of corticosteroids in rheumatoid arthritis in all the rheumatological conferences, international rheumatological conferences that we participate in. So the glucocorticoids in rheumatoid arthritis is given at a low dose for short periods of time. There's scarce evidence on optimal tapering strategy, scarce evidence on long-term safety and efficacy. There's even no evidence or scarce evidence on optimal duration of therapy. Recommended dosage at the moment is not more than 10 milligrams per day for not more than 6 months, with tapering quickly as clinically feasible. It is used as bridging therapy till disease-modifying drugs take effect. When you start a disease-modifying drug, and because they take 2 to 6 months to take effect, you bridge the treatment with glucocorticoids. And after many years of use in rheumatoid arthritis, it is now when we have the glucocorticoid low-dose outcome in rheumatoid arthritis study, which is ongoing, and is evaluating the safety and efficacy of additional long-term low-dose corticosteroids, about 5 milligrams per day versus placebo over 2 years. And the research is ongoing, and this probably will be one of the first studies that are done on corticosteroids in rheumatoid arthritis. The EULAR task force on rheumatoid arthritis recommends that risk of harm of note the risk of harm for risk of harm is low for long-term use of corticosteroids, low dose, like 5 milligrams per day. The risk of harm is low, but risk of harm increases for doses more than 10 milligrams per day. So between 5 and 10 milligrams per day, consider patient-specific factors like age, gender, genetic predisposition, comorbidities, and individual lifestyle like smoking, alcohol, and alcohol consumption, the nutritional status of the patient, and whether the patient is active or not. All these need to be taken into account. So you have to decide on the risk-benefit ratio. But we recommend low doses of about 5 milligrams, and this is considered to be safe. The EULAR guidance, therefore, consideration of glucocorticoids in all situations where conventional synthetic disease-modified drugs are initiated or changed. So whenever you are initiating disease-modifying drugs or changing from one to another, you should bridge the gap with the corticosteroid. And they also recommend higher starting doses and gradual tapering, stopping within 3 months, but not more than 6 months. So high doses of corticosteroids, we use it when we are initiating treatment and when we are changing a treatment with gradual tapering. But this issue of tapering strategy will be better understood after we get results from the GLORIA study, which is ongoing. What are the new formulations of corticosteroids? There's modified release prednisone, liposomal glucocorticoids, and associated agonists of the glucocorticoid receptors. The modified release prednisone controls rheumatoid arthritis symptoms which occur in the morning hours with sleep disturbance, which occur with evening administration of glucocorticoids. It's already registered for use. What it is just conventional prednisone encapsulated in a way that it delays its liberation by 4 hours, allowing for convenient administration at bedtime. Usually, the symptoms of rheumatoid arthritis tend to be exacerbated early in the morning. So we want that if a patient takes it, the release is delayed, and around early morning is when it is released, so that the patient benefits from symptom control when they wake up in the morning, so that the morning stiffness that you see in rheumatoid arthritis is absent. Because we use it for symptom control, that's why we use it at night, but we are already being told about the issues of adrenal suppression by using more than once. Then liposomal glucocorticoid is an encapsulation of conventional drugs with phospholipid bilayer. It improves the pharmacokinetic and pharmacodynamic of the drugs. The layer is biocompatible and biodegradable, and it accumulates at the site of inflammation. So you have high concentration at inflamed joints or affected sites. This reduces the required systemic doses, thereby minimizing the undesired effects at other organs and tissues. There's promising animal studies showing superiority to free agents and superior to even infliximab and even etanercept that we use at the moment in terms of symptom control. There's also dissociated agonists of glucocorticoid receptors. So glucocorticoid achieves its action by, normally glucocorticoid achieves its action by transactivation and transrepression. Transactivation method binds to DNA binding sites and induces transcription and translocation of specific proteins, and is responsible for the undesired effects like hyperglycemia and osteoporosis. But transrepression mechanism involves interaction with the transcription factors to inhibit synthesis of other proteins, and this is responsible for desired anti-inflammatory effects. So dissociated agonists of the GC receptor achieve their receptor conformation that favors transrepression over transactivation. So you minimize the side effects and promote the desired effects, and this results in preserved anti-inflammatory capacities and reduced adverse effects. It also is promising in animal studies, and we hope that this will hit the market soon and will be beneficial to patients who require corticosteroids. So the glucocorticoids, glucocorticoids provide fast, effective weapon against rheumatic diseases decades ago. Enthusiastic acclaim in rheumatoid arthritis was followed by several decades with little scientific attention. It is a reliable ally whenever needed. Today, glucocorticoids are far from being obsolete. DMARDs, when co-administered, it's used for with the DMARDs when it's administered with disease-modifying drug in low doses, and is among the most prescribed drugs in rheumatology. And most of the doctors, when they get a patient with a rheumatic condition, the first thing they think about is glucocorticoids. Active research on the new substances and better understanding of the conventional agent is ongoing, and I think it's going to give glucocorticoids to experience a new youth. And like an old friend, they will continue to keep us company in the ongoing fight against rheumatic diseases for many decades to come. Thank you very much for your attention.
Thank you very much, Professor Oyo, for your presentation. We cannot discuss rheumatology in this country without inviting Professor Oyo. And we are very privileged today to have you on board. Thank you very much for your great presentation. And we want to thank our other presenters, that is Dr. M.D. Minor and Dr. J.A. Loch, for their presentation. So I will allow AVACARE to make a brief presentation, even as we allow the panel of speakers to actually look through the Q&A, even as I'll be reading them out aloud. So AVACARE team, kindly 5 minutes so that we can have time to actually let the speakers breathe and start our Q&A.
Yeah. Good evening, everyone. Am I audible, Doctor?
Yes, we can hear you. Continue.
Yeah, AVACARE Kenya, we welcome you all for this particular evening session, where the objective was to understand the oral corticosteroids, which are there for almost 7 decades, but a better understanding was needed, with specific focus from our side on the prednisolone being our product, for their unique place in the management of various acute inflammatory conditions across the specialties, and also the challenges that this class of drugs pose, which was well explained by the speakers. That was wealth of experience with which they've shared their knowledge. Would like to thank all the panelists for sharing their experience on the oral corticosteroids. AVACARE as a group, we are operating in about 22 countries across the African continent. We are an African company. For more than 23 years, we have collaborated with many of the world-class manufacturers across the globe, including the one in reference right now, which is Botu from Morocco. In Kenya, we have a vision to market unique and quality products, pharmaceutical products, and that can add value to the prescription of all of you at an affordable price. To present a few of the products, including the product in reference, I would take a few minutes of all of you. The first product, obviously, that we are looking at being Corticosteroid, the only effervescent prednisolone 20 milligram tablet available in Kenya. Indications has already been discussed. There are many indications where we are basically talking about the acute symptoms where you need a short-term therapy with high-dose prednisolone, which include the likes of asthma, COPD, rheumatoid arthritis, gouty arthritis, cancerous conditions, and ulcerative colitis, severe allergies, and also in nephrotic syndrome. Why Corticosteroid when 5 milligram prednisolone is available? In acute inflammatory conditions, when for an effective pain relief, when a patient needs high dose prednisolone, Corticosteroid basically reduces the pill burden. Titration of dose, whether it is possible. Oral corticosteroids, titration of dose is most important aspect. It is a score tablet. So from 10 milligram upwards, the titration of the dose is possible. How is it compared to the prednisolone syrup that's available? Corticosteroid is palatable when you make a solution out of the effervescent tablet, and it can be easily administered to children, unlike the available syrups in the market, which have quite a bitter taste. It is manufactured in Morocco by our partner, Botu Laboratories, which is the second largest company in Morocco. Morocco being a regulated market, it is manufactured under stringent manufacturing conditions. Corticosteroid is a bioequivalent formulation. Product is also packed in a HDPE bottle to promote product stability. Price-wise, yes, it is also a fact that oral corticosteroids are preferred also because they are cost-effective. That still remains same with the Corticosteroid because compared to 5 milligram generic prednisolone that's available, which definitely poses the pill burden aspect, whereas Corticosteroid, with all the uniqueness and the quality of the product, it still matches with the 5 milligram product that is available. Corticosteroid basically comes in a pack of 20 tablets. That's the score tablet that we said, which is for dose titration. This is about Corticosteroid. I'll also indulge into mentioning a couple of other products of ours, which would be relevant to this audience. We have got a product called Digiva F, which is an antacid for sure, but it's only antacid sachet available in Kenya, which has got magnesium hydroxide, aluminum hydroxide, and also it has got antiflatulent in simethicone and carboxymethyl cellulose. Most patients, why sachets they should take? Because antacids are taken not on a SOS basis, not on chronic basis for most patients. There are some patients where the chronic usage of antacids happen, where bottle would be of use. Otherwise, for most patients who need once or twice, when they have symptomatic problems and they would like to get a symptomatic relief, after opening the seal of the bottle, antacid should be consumed within 15 to 20 days. Usually this poses a chance of medicinal wastage and also becomes expensive too. So to overcome these challenges, AVACARE Kenya is introducing these Digiva sachets, which basically with the uniqueness of the product, it also costs about 10% of the bottle cost, which makes it much more economical. Digiva is also palatable with universally acceptable mint flavor. It has got less viscosity unlike the other antacids, so it does not leave any deposits on the buccal cavity. Also, there is no metallic aftertaste when you use Digiva. So, we have got these two packs, which is a 10 ml sachet, and we also have a 170 ml bottle pack. Then we have got eticoxib, which is an NSAID, the best suited pharmacokinetics that it offers amongst the NSAIDs, because the onset of action starts in just 23 minutes of its administration. It's the fastest acting NSAID. Also, it acts for 24 hours because of why it also offers once a day dosage advantage. It also provides excellent analgesia in acute as well as chronic painful conditions. Atrib is the highest offers the highest selectivity of COX-2 inhibition, because of why you have the better GI safety and also comparable GI tolerance. So in many of the conditions in acute or chronic segments, you have ATRIB as a product. And lastly, to close it, we have a range of probiotics. Our probiotics are all symbiotics with a prebiotic and also probiotics. We've got advanced rescue, which most of you would be knowing. It has got 10 different strains of prebiotics and probiotics. It helps in not only in terms of managing the antibiotic-associated diarrhea, also co-prescription with H. pylori kits to avoid the GI irritation and also irritable bowel syndrome and even gastric ulcers and gastritis. And Daily Flora is our product of that really gives much better benefit in dyspepsia and also bloating and chronic indigestion, etc. Then the second last product that we have is Femiflora, which is more for recurrent UTI and also for VBC, where 5 well-documented strains of lactobacillus are being given, along with the natural cranberry extract and also D-mannose. And lastly, we have this Colon K, which is a natural laxative, which also helps in terms of really helping. So thank you so much. We really appreciate the space being given to us and to really give our own brief about our company and a few of our brands. We really thank KMA for giving us this opportunity.
Thank you very much to the whole of the AVACARE team for supporting this CME. Indeed, we have had a very powerful panel and we have learned a lot. I think where the Corticosteroid, I think, will go a long way in assisting patient compliance with having patients take at least one tablet or this, as opposed to having 4 tablets, especially for the ones who are in acute phase and are having a higher dose of corticosteroids. I will go straight ahead to the Q&A, and in the interest of time, we have about 10 minutes or so to address the questions. So I will address some of the questions, and some of them we shall be able to share with the panelists, and they will be giving us answers, and we can email to you. So the first question I will direct to Dr. J.A., and it is asked by Manisha Chandaria: are steroids safe to give in pregnant women with acute asthma attack? Dr. Aloj?
I can hear you, yeah?
Yes. The question is, are steroids safe to give to pregnant mothers with an acute asthma attack?
Yes, they are safe. Of course, it depends on the days. But let's get it correct. There are 3 conditions that over the years, a lot of clinicians have been very cautious in using steroids. One of them is patients with suspected peptic ulcers. The other patients with maybe old TB, and of course, thirdly, in patients who are pregnant patients. It's safe in all these cases. And even in children, for a long time, a lot of pediatricians have been suffering from what has been described as sterophobia. That's a fear of steroids in children, particularly, because of maybe stunning the growth. But it's been shown that severe asthma, poorly controlled, causes more growth defects in children than may be possible overuse of steroids. So steroids can be useful, particularly in severe asthma, in any of those conditions, pregnant women or not pregnant women, patients with asthma, or patients with possible relapse TB, or small children.
Thank you. Before you go off, Dr. Aloj, the other question is from an anonymous attendee, and they're asking, can corticosteroids be used as a prophylactic drug in case someone already diagnosed with asthma is traveling to a place prone to allergens? I presume this question is regarding long-term use of corticosteroids.
Yes, you can use them as a prophylaxis, our controller, as you call it, and I said it before. And in that case, you use it as inhaled corticosteroids, not long-term oral systemic. So inhaled corticosteroids are actually used as preventer or prophylaxis, whatever you call it, basically to stop you from having a severe attack of asthma. Yes, you can use it, but you must modify ICS, not OCS.
Thank you very much. And just for clarity, ICS is inhaled corticosteroids. To Professor Oyo, Dr. John Wekesa asks, what is the indication and benefit for intra-articular injections of glucocorticoids in affected joints?
Thank you. In patients with rheumatoid arthritis, even given the best DMARDs, occasionally you get one joint which is more symptomatic over the other joints. And the aim of management of rheumatoid arthritis is pain control and returning the patient to their normal activities. So when the disease-modifying drugs are taking long to modify, to give symptom relief in an inflamed joint, a single inflamed joint, is always you give corticosteroids, and that give instantaneous pain symptom control as the disease-modifying drug take effect slowly. They usually call disease-modifying drug or slow-acting antibiotic drugs, but we use the disease-modifying drugs because nowadays we have those like biologics which act pretty fast, very, very fast, and no longer take months. So for quick symptom control, and this can be used in rheumatoid arthritis, in osteoarthritis, in gout, and any other situation where there is non-infectious inflammatory joint disease, and it gives symptom relief as soon as possible. In fact, immediately.
Okay, two questions for you, Professor. One is from your presentation, an attendee asked whether rheumatoid arthritis can be reversed with medication, that is advanced rheumatoid arthritis, whether it can be reversed by medication, that is function return of deformed joints. And two, what do you do with patients who cannot afford DMARDs? Can you use oral glucocorticoids, and at what doses and intervals?
Thank you for that question. The reason why we talk about rheumatoid arthritis, one of the goals of treatment is early diagnosis and early initiation of treatment. And the reason why I talk about this, because once joint erosion has occurred, it is irreversible. Erosion of the bones of cartilages and bones of the joints is irreversible. So once deformity has happened and due to erosion, that cannot be reversed. However, you can control symptoms and prevent further progression of disease. That's why we say that once a diagnosis is made, a patient should be initiated on disease-modifying drug within 3 months of diagnosis so that you prevent erosion. So to answer that question, deformities is actually represent erosion of the bones which cannot be reversed. Tendons which have been ruptured cannot be reversed by medication unless you use surgical methods or repair and so forth. Is it feasible to use corticosteroids in lieu of DMARDs because somebody cannot afford DMARDs? The answer is no. You know, corticosteroids are one of those medications whose side effect profile is well known. And you saw how Dr. Lodge and Dr. M.D. Maina really gave us a long list. Those, in fact, when you use corticosteroids, somebody is going to get some of those side effects, and this is sure. You know, if you use non-steroidal anti-inflammatory drug, you may get peptic ulcer disease. Not everybody gets. There are those who are predisposed to get peptic ulcer disease. But steroids, when you use, you are going to get osteoporosis. When you use it for a long time, you are going to get hypertension, diabetes, and so forth. So we do not we do not advocate using them instead of disease-modifying drugs. I think the most important thing is to make drugs accessible and affordable for all chronic conditions, including rheumatoid arthritis, so that we use the right medications and with the little side effects. But however, there's a study going on now looking at use of low-dose corticosteroids with other medication safely as a disease-modifying drug, and the Gloria study will give us some answers to those questions. But it is used at a low dose as a disease-modifying drug in combination with other medications. combination treatment in rheumatoid arthritis is one of the key strategies in management of rheumatoid arthritis. Use combination so that you use combination drugs at lower dosages so that you benefit from the efficacy and you don't slide into the side effects that those drugs have when they're used in high dosages.
Thank you. Last question on the musculoskeletal system is how David Omega asks, how can I be an athlete when using steroids for rheumatoid condition, yet steroids are banned for athletes? I presume they're asking if they want to, if they're an athlete and they're using steroids, can they still compete in competitive sport?
I think we have heard of, I think the steroids which are banned in athletes are the anabolic steroids, the ones which are enhance performance. But athletes, when they are going for testing, they usually declare their health status and any medication that they take. And I think these are usually taken in consideration when analyzing their urine. And we know those who have gotten gold medal, even with asthma, using the inhaled corticosteroids. So I think there is even the testing usually looks at how much corticosteroid you are using. You know, when you use it for performance enhancing, usually very high dosages, and they are usually picked. So I think the testers are usually probably medics, and they know what they are doing. But once they declare, I think probably I've not been in this area of testing for drugs, but I'm sure once you declare what you are taking, that will be taken in consideration when they are giving the results and deciding whether you are using it for the wrong purposes or not.
They normally come with a report from their doctors, and some of them are known, particularly in asthmatic. We got a lot of asthmatic who are athletes, and we had even, I remember I used to treat one here who actually was 800 meters gold medal. The inhaled corticosteroid, they may not a lot of it is absorbed, fortunately. So you don't have very high doses in systemic. And with the current system of delivery, you reduce the amount of absorption of inhaled corticosteroids, particularly with the nanotechnology. So I don't think it's a big problem. Those who are taking growth or enhancing steroids are in a different class, and you can't mistake them.
Thank you very much. Dr. MD Minor, I have there's a participant who wants to ask a question here regarding the role of prednisone to manage hypersplenism in massive splenomegaly resulting from schistosomal portal hypertension. So they're asking, can you use prednisone to manage splenomegaly from schistosomal portal hypertension?
Now the answer is no. There is no indication for steroids when you're treating splenomegaly because of things like schistosomiasis. Now, it should, I think the participant should appreciate that steroids, the dosage we are using for steroidal therapy for splenomegaly or ITP will normally be immunosuppressive doses. So the core purpose of treatment is to give immunosuppression, but this will not have any effect on things like schistosomiasis. Because in schistosomiasis, what is happening, patients develop periportal fibrosis, they develop portal hypertension, and then splenomegaly. So it's really a mechanical kind of splenomegaly, so it will not respond to steroids. So that is not recommended and should not be used.
Dr. Minor, I hope you can answer the following 3 questions for us regarding tapering off of steroids. One person asked, why is tapering off of drug essential in patient monitoring? The other one is, when should one stop use of steroids? And the last one is, if we use dexamethasone for 2 weeks at a lower dose, as in the case when we are giving radiotherapy palliatively to the spine, do we need to taper it off?
Now, let us use ITP as a condition which we can use to explain the use of the steroids. Now, for patients with ITP, when you're starting your treatment, the doses are quite high, 1 milligram per kilogram of body weight. Now, most of the patients will be on this dosing probably up to a whole month. At that level, if you find you have achieved your target platelet count, then you start tapering off. Now, the catch point will be, as you taper off, you could find that as you go down the dosing, then you find the disease is relapsing. So if at 3 months, you are not able to control ITP at the smallest dose desirable, then your ITP treatment on steroid is not working. So if you are if you identify it is not working, it means you'd have to do something different. Now, other things which you can use after 3 months and it is not working, because you would have to use things like either immunoglobulin or go to second line therapies, where nowadays we are using rituximab. And in extreme circumstances where like these things like rituximab are very expensive, so most of our patients will not. So splenectomy has been used as an alternative in that scenario. So, but there is no cut-off line to say you should stop steroids now. There are some patients who are on something like 10 milligrams of prednisone. They have platelet counts like between 20 and 40 there. They are not bleeding and they're able to go on with their own lives. If you reduce it to 10 or 5, then the platelets come down like 10, where they reach a bleeding threshold. So this requires a lot of balancing act. It will depend on what you decide. Because if the risk of bleeding is very high, they need steroids. If the risk of side effects is too high and the benefit is little, then you must stop the steroids and go to the best treatment. So there are no hard rules here. Also, what I would suggest to the doctors who are treating things like ITP, in the first 1 month, it's vigorous treatment. After 3 months of treatment and the response is very poor, you cannot get the platelets above bleeding threshold, then you should go to the second line treatment. The other question was what? That one tends...
all on tapering off. When should you taper off? If you're using dexamethasone, like for palliative, for those in palliative care, when do you taper it off?
If you're using low dose dexamethasone, you really don't have to taper off. You can stop without any issues. If we can use where we do like myeloma, we are giving myeloma treatment for a long time. By the time you complete 21 days, 6 cycles, you are giving them 40 milligrams per hour weekly for up to probably 3-4 months. And we don't taper, the protocols don't tell us to taper off the dosages. Once you are through with the treatment, you stop it. But for things like prednisone, tapering off is much more clearer than when you are using the dexamethasone. So for those people who are doing radiotherapy, I think with the kind of doses you are using, low dose, you can be able to stop without any issues.
Okay.
I think Liz, if I may chip in, I think the issue is a little different in asthma. As I said before, we used to taper off steroid in asthma, but that was before we popularized the use of inhaled corticosteroids. So now instead of tapering the dose of steroids, oral steroid, you rather induce the patients to use inhaled corticosteroids and make sure they know how to use it well, because most of them fail not because the IC is not working, but because they're not using it properly. So you have a time to train them on how to use it and make sure they use it properly. Then you can taper off oral corticosteroids. I mean, you not taper, but stop. You don't have to taper. And this should take not more than 3 weeks ordinarily. If you're going beyond 3 weeks, then there's something very wrong.
So thank you very much, Dr. J. Aloch. Final question to the team is regarding the risk of COVID-19 on patients on long-term ICS. Have you seen any increased risk among your patients with asthma who are on long-term ICS?
The answer is no. And the patient on ICS continue using the same ICS with or without COVID.
Thank you. So, ladies and gentlemen, my fellow colleagues, thank you so much for logging in. I have noted your various comments regarding the distribution of the slides for this webinar. We shall be sure to share the slides of this webinar to the participants once we have gotten approval from the presenters. This webinar has been recorded and shall be available on various platforms, shall be available on the KMA YouTube page, shall be available on our e-learning platform for your review even after this. Thank you very, very much to all our participants for joining in, for supporting KMA, and for your need for learning, even during this COVID-19 period where we have had to move everything offline. We want to thank the KMA team for continuously working day and night to ensure that we continue to provide learning opportunities for our members and all the doctors. And we thank our members for entrusting us with this role. I want to thank you so much for the KMA members. We want to thank you for your support and also ask you, for those of you who need your subscription, to do the same so that you can be able to having these webinars always. For those who have not joined KMA, we are very happy to have you as our member. Kindly log into www.kma.co.ke and log into the members portal and join to be a member. Thank you so much to our presenters, Dr. J.A. Alot, Dr. M.D. Maina, and Professor Omondi Ayo. We are very, very grateful for sharing your wealth of knowledge on corticosteroids. We have had very great participation, very good questions coming in, and I'm sure this presentation shall be shared widely. I also want to thank the AVACARE team. Thank you for supporting the learning series to Kenya, and thank you for providing quality medication to our doctors in Kenya. As you log off, on your screen, you have our webinar for tomorrow. We have been having COVID-19 webinars every Tuesday evening on the mental health, and every Thursday afternoon we are discussing case management and other conditions that are affected by COVID-19. And tomorrow we are happy to be hosted by the Critical Society of Kenya, who shall be discussing acid-base imbalance and ABG interpretation. Join us at 2 p.m. Please find the link on our various KMA social platforms. Thank you so much, ladies and gentlemen, and I wish you a good night. Peter.